Thank you very much for the introduction. And I'm very glad to be part of this International Visiting Professor Program. My name is Sjirk Westra, and I'm one of the pediatric radiologists at the Massachusetts General Hospital. And the mission of this session is to promote excellence in patient care and health care delivery through education, research, and technology innovation. I had the opportunity to travel to a number of countries, and I would love the opportunity in the future to visit Lebanon as well. This webinar was organized in conjunction with the Society of Lebanon as well. So here's the invitation that you all received, and I'm very privileged to be part of this. I will be the first speaker, and I will talk about rational use of pediatric emergency CT. And as prepared for this lecture, I looked at the hospitals, and there's many centers of excellence located in Beirut that are collaborating with American institutions as well, with beautiful campus located right by the ocean, and I would like to visit one of those places one day. The host of today is the Lebanese American University Hospital, the Rich Hospital, where you are all now attending my lecture. It has a rich history, as I understand it, and I can see that there's progress going on, buildings are going up, and collaborations are moving forward. And you can see here, this is one of the newer hospitals, and many of you could work there. New equipment is being installed as we speak. The first PET CT scanner with 64 slices. At the same time, I think your audience is very familiar with the concept of radiation protection in children, and I was able to find this paper by Dr. Charbel Saad, who looked at the radiation dose and opportunities to reduce the dose in adults and children alike. Now, I'm a pediatric radiologist, so I'll focus on pediatric CT, rational use in pediatric emergency departments. And I work in the Massachusetts General Hospital, which is also a very advanced hospital with many imaging modalities, PAC system, PET CT, PET MR, lots of developments going on. And this is our hospital 10 years ago, and as progress continues, new buildings are going up, probably funded by the revenue of all the CT scans that we are doing in our hospital. So this is a new building that got up with several newer scanners, including multi-slice CT. Now, CT has a long history. I've been involved with most of this, and I'm fortunate to see some of these images in 1971 with the original AMI scanner. And basically, we had very little to worry about. We just looked at the window and level on the monitor, and we looked at those images which revolutionized medical imaging, enabling cross-sectional imaging of the human brain for the first time. Now, in 2016, we have dual-source multi-detector OCT, which can image a trauma patient in a matter of seconds. And you can see here a case of CT angiography of the chest in a trauma victim. And this image is literally acquired in several seconds, showing the skeletal and vascular anatomy in exquisite detail. And what is shown here is a left-sided sternoclavicular dislocation, as you can see here in this volume rendition. Now, this image is acquired very quickly in the trauma room without the need to move the patients from location to location, and very useful imaging information is being acquired very quickly. But as a result of the success of CT, we have seen in the United States at least a marked increase in the utilization of the technology, and that had, as a result, that there is more radiation exposure per capita, which is shown by the red triangle here, between the 80s and current time. So there are a number of accidents that happened, clear overdoses that were resulting from ignorance and technologists struggling to immobilize a baby and repeating scans up to 150 times over 65 minutes here in California. And this child suffered some radiation damage with a burn around the head. And that raised some concerns with the public, and even lawsuits have resulted from this. So pediatric patients, of course, are more sensitive to the effects of radiation than adults are. And that's why even in the New York Times, there were articles that stated or claimed that we are giving ourselves cancer with all the use of CT. It's a controversial article written by a cardiologist and a radiologist as an opinion article in the New York Times, and responses to that have emerged from the radiology profession. So what are the risks of pediatric CT? It's not just the radiation risk. Luckily, we are able to sedate children less because of the fast scanners. Some scanners the gantry travels at a speed of 60 centimeters per second, so there's less need for sedation in children. Now, the sedation, as it is being administered, can cause acute reactions needing admission in the ICU. And there's now some papers coming out of anesthesia in young children causing developmental delay or being implicated in developmental delay and learning disabilities, attention deficit disorders. Anaphylaxis is the biggest risk that we fear as radiologists. Risk of very low, 1 in 75,000, but sometimes we actually consent patients for this very low risk. Then there's the radiation carcinogenesis risk, which is estimated, extrapolated from Hiroshima data to be in the order of 1 in 10,000, depending on the dose of the scan. And this is controversial, of course. But there's other risk. Incidentalomas could be detected, lung nodules, adrenal nodules, thyroid abnormalities that require further workup, and the detection of what's called pseudo-disease and overdiagnosis. So let me illustrate that with the case of acute appendicitis as it presents itself in the emergency room. I've been familiar with the technique of graded compression ultrasonography. I was trained in the Netherlands, in Amsterdam, and Dr. Julian Pauwelaert introduced the technique, published it in Radiology in 1986. 10 years later, the technique of focused appendiceal CT was developed at Mass General Hospital by Dr. Rao, and it's basically doing an enema on the CT scanner with cross-sectional imaging. It was determined whether or not contrast entered the appendix. Now, the clinical signs of appendicitis are very well known, and many surgeons will operate based on just the clinical findings alone, but imaging has become more and more prevalent in this diagnosis, including children. Now, appendicitis is a moving target as well, because now we see that some cases of appendicitis are no longer surgical conditions, but they can be treated with antibiotics. If you catch it very early, it can actually be cured by antibiotic treatment. This is a new article out of Finland that shows that it's no longer a surgical disease. On the other hand, some other cases are missed, and they perforate, and our job is to pick it up before the perforation occurs. So we use CT predominantly in the past with a variety of contrast materials. It has the highest sensitivity and specificity. The problem, of course, in children is the lack of retroperitoneal fat, so we don't always identify the normal appendix, and then the radiation problem that I mentioned earlier. Ultrasound is a very valuable test in experienced hands, particularly in girls, where we can also look for alternative diagnoses, such as ruptured ovarian cysts. So nowadays, the emerging protocol is to use ultrasound as an initial screening test and reserve CT for intermediate a priori probability cases, or when there's a suggestion of the appendix being perforated. When we're talking about doing a test, we have to ask ourselves, what's the indication for doing it? And I put side by side the words indication and standard of care. Indication is based on objective appropriateness criteria as are developed by the American College of Radiology. They're universally applicable, so in Lebanon the same rules apply as they are applying in the United States or any other part of the world. They are evidence-based. They are basically universal. Standard of care is very much dependent on the locally available resources, number of doctors, number of scanners in a particular region, clinical expertise and interest, and of course the money. Money dictates also what's going to be done. Regional variation is a result of that in the United States and other parts of the world as well. It's not evidence-based, and it's more a legalistic term that's being used. Now, what we can do in order to reduce the use of CT, we can do a pediatric appendicitis score, which is a clinical priority a priori test that determines the pre-test probability of appendicitis, and it has been validated now in many large academic medical centers. So some cases are so obvious that surgeons are confident to operate them without any imaging. Others are clearly negative based on this score. And the algorithm of doing ultrasound first, followed by CT, is being adopted by many centers in the United States, including the Stanford study in 2009 to reduce radiation exposure by doing more ultrasound exams. Tel Aviv has a study in pediatric surgery, and then also the Children's Hospital Boston published in Pediatrics. So now there's more and more ultrasounds are being done for acute appendicitis, particularly in young children. And if they are clearly positive, the patient goes to surgery. If they're intermediate, maybe an additional test, even an MRI has been advocated in some centers. And when they're clearly negative, then the patient doesn't need any further workup. What we always worry about as diagnosticians and radiologists in particular, we worry about missing something. We have a false negative result. The patient is allowed to be perforated. And this has to do with the sensitivity of our test, the negative predictive value. We may just simply overlook a subtle case. And here's a case on CT, a 12-year-old with right lower quadrant pain, where we at Mass General frankly missed the diagnosis because we've concluded that the pain was caused by this ovarian cyst that we see here. There's some inflammatory reaction. And these are the relevant images that were overlooked by the emergency room that shows an inflamed appendix with stones in it. So the patient went to another hospital and then perforated and had more complications as a result. A false negative CT result. Now, false negative result with CT results are rare, and they are more common with ultrasound because you cannot always find the appendix by ultrasound. It was a gangrenous perforated appendicitis. Computed tomography with intravenous contrast alone, which is the preferred method, is only helpful when there's some abdominal fat surrounding the appendix. So in many children, we don't really see the appendix that well, and it's hard to show a normal appendix in those cases. And we have not technically ruled it out, so we have to go by the appendix score. Another problem that we can run into is overdiagnosis or misdiagnosis. We have a false positive result, and that has to do with the specificity of our test, the positive predictive value, and the threshold of detection. If we lower our threshold, we're going to call more cases abnormal. So we can label the patient with the wrong disease, the disease that he doesn't have. We can pick up an incidental finding. We can misinterpret findings. And this all has to do with the validity of the test and the indication of the test. It is equally common as missing cases, but it's probably, it has as many implications for us as radiologists because overcalling is probably better than undercalling. That's what most people feel. And here's an example of a 12-year-old girl who had recurrent abdominal pain, and we can see that the appendix is normal with air in it. But sure enough, if we look through the whole scan, we see a number of enlarged lymph nodes. And this patient then was diagnosed with mesenteric lymphadenitis. And in fact, the child had normal lymph nodes there. This is very common to see this in adolescents. And the child had the pain miraculously disappearing in the weekend and came back on Monday again. This was a child who was bullied at school, and it was a psychological case of abdominal pain rather than the adenitis bothering the child. So if we do imaging, we may label the child with the wrong diagnosis, and that may also lead to excessive treatments and unnecessary workups. This is an example of pseudo-disease detected by CT. Now I'm going to talk a little bit about the use of CT in children with pneumonias, particularly when they're recurrent. CT is helpful, and here we have an example of a patient with an unusual type of pneumonia. You can see some volume loss, an abnormal bronchial tree. The patient then underwent treatment. The pneumonia almost cleared, but you can still see a little bit of irregularity of the lung markings in the right upper lung zone. Sure enough, by the follow-up CT, we could see there was a hyper-aerated segment in the right upper lobe with an abnormal bronchial shadow containing a small bubble within the bronchus, and this was a case of an underlying bronchial abnormality called bronchial atresia that required surgery. So in those cases, when there is recurrence of pneumonias, you can look for sequestrations and other congenital malformations of the bronchial tree or the lung development. CT is helpful to show those features. Also, children with underlying immune deficiencies, such as leukemia. When they get ill and admitted to the ICU, and we see this child is compromised with 2 chest tubes, subcutaneous air in the chest wall, leakage of air, high pressure ventilation. Cross-sectional imaging can help to be more specific about the diagnosis. And this patient had multiple lung nodules scattered throughout the lungs. Some of them are cavitating, and was diagnosed with an opportunistic infection, invasive aspergillosis, which is a specific condition that requires specific treatment. So CT is helpful in complicated pneumonia cases in children, in immunocompromised conditions in particular. And ultrasound is actually better than CT to guide treatment decisions when there's pleural complications, such as empyemas. Ultrasound can guide the placement of chest tubes better than CT in real time. Ultrasound is better to show septations within the pleura than ultrasound than CT is. CT is used to look for congenital malformations, as I mentioned, and also complications as bronchopleural fistulas. And then the demonstration of lung necrosis and cyst formation on CT does not really affect the outcomes of the patient. So even though the findings are very vividly shown on CT, there is no treatment implication for necrotic pneumonia. I want to show you this, now switching over to the trauma cases, I want to show you this 10-month-old boy who underwent a motor vehicle accident. And of course, when a young child arrives in the emergency room, all the resources are pulled out to make a quick diagnosis. The child had a head trauma, and you can see here there's some blood intracranially and extracranially, which requires 2 follow-up scans, causing a total radiation exposure to the brain of 90 milligray, which is somewhat worrisome. There's another paper that I want to bring to your attention of impaired cognitive function from cranial radiation for hemangiomas by Dr. Hall in the British Medical Journal. So this raises the question, how many CTs does a patient like that needs to undergo to follow this up? It's so easy with the multi-detector slide scanner to, we can do the plain film of the C-spine and we can see the normal alignment and no obvious fracture, but we can just push the button and do the whole body scan, the pan-CT as is done in adults. This is another 15 milligray of dose over the cervical spine. And the C-spine series has a 14-fold lower radiation than a CT scan. So one could do extrapolations of the amount of cancer induction of the thyroid by the trauma CT. Also realize that in children we often don't see radiographic abnormalities, and there may be severe spinal cord abnormality, the Sjirk condition, cervical spine injury without radiographic abnormality. So in those cases, MRI may be more helpful than CT. The patient underwent a PAN, the total body CT, and had another scan of chest, abdomen, and pelvis. And we see abnormalities in the lung, but this radiation dose is probably unnecessary in order to manage this patient. So this is a new, unfortunately, a development that we see, at least in our center, that the patient arrives in the emergency room and enters the emergency room to a scanner and then gets evaluated, and it seems very sophisticated and computerized, but I think it's important to keep looking at the patients clinically and do clinical assessments based on physical evaluation of the patient rather than this scenario that you see here. So minor head trauma, I've shown you the example. What are the cases that benefit from imaging? Presence of symptoms as dizziness, sensory deficit, Glasgow coma score of lower than 13, or in other words, comatose children who cannot be assessed clinically very well, mental status changes, seizures that are not related to the direct impact. Bicycle injury is often more associated with severe head injuries than other forms. The child being younger than 2 years is difficult to assess clinically. And when there's palpable skull defects and fluid coming out of the ears or other findings of basilar skull fractures, cranial imaging is required in those cases. Here's a trauma victim with a splenic laceration. with active bleeding going on around the spleen. The spleen is scattered, and sure enough, there are extensive findings in the chest as well. Pneumothoraces, fluid levels within the chest here. Pneumothorax, the patient was actively bleeding. And it's clear that this patient requires emergent intervention with chest tube placement. Another trauma patient, an adolescent who suffered a severe blunt chest trauma. And you can see that there is basically pneumo everywhere in this patient. There is pneumo in the pneumothoraces that have to be drained, soft tissue air, and a patient who has continued drainage of air from chest tube requires a CT scan for the underlying cause. And here you can see this very dramatic CT scan showing pneumoperitoneum, pneumopericardium, pneumomediastinum, and severe barrel trauma to the lungs. Patient underwent detailed imaging showing the rupture within the bronchial system with air dissecting within the mediastinum and the rest of the patient's body. This could be repaired through endoscopy, and the outcome was very good in this patient. CT is essential in a case like this. Or images that show the air dissecting within the interstitium and the bronchus intermedius. When we're dealing with a child that underwent a high-speed motor vehicle accident, and the child had to be intubated at the ICU in the emergency room already, we have to look carefully at the mediastinum, and if we see displacement of the NG tube or the main stem bronchus, we see a small amount of fluid overlying the apex of the lung. That could be a sign of traumatic aortic injury. They're very uncommon in children, but this is the only case that I have been involved with, and you can see here the pseudoaneurysm that formed as a result of this deceleration trauma. That's a critical emergency that requires surgical or endovascular treatment. Here you can see a coronal image that shows the leaking aneurysm, time bomb ready to go off. It is very important to pick that up in the trauma room. But I reiterate, this is a very rare condition in young children. This was treated with stent placement through an endovascular treatment. Another trauma, blunt chest trauma victim, the child underwent chest tube placement on the left, and we can observe on this scanogram that there is an abnormal contour of the left hemidiaphragm. And the diaphragm is a very tricky part of the body. It's difficult to image by ultrasound. So I think cross-sectional imaging with CT is extremely helpful to show, in this case, abnormal fatty densities above the left hemidiaphragm. Difficult to appreciate in the axial plane, but much easier seen in the coronary format, as you see here, a defect in the left hemidiaphragm with abdominal fat herniating into the chest. And also air from the pneumothorax in the abdominal cavity. So this is important to pick up. The diaphragm is a very thin structure, so you have to go through the slices very carefully, and this is a surgical condition again. It requires repair, because otherwise this patient may present with bowel herniations with prolonged time interval. When we do a chest film in a trauma victim, we have to look carefully at the various pleural lines, and this patient did have thickening of the paraspinal line. High index of suspicion caused the CT to be performed, and here we see a paraspinal hematoma adjacent to a non-displaced fracture in the thoracic spine. This patient didn't have any neurologic symptoms, but still it's important to immobilize this fracture. So there's a good indication for trauma chest CT. Obviously, when there's displacement, which is quite rare in the chest because the thoracic spine is quite well protected by the rib cage, but in bad high-energy trauma, you can have a complete dissection of the core. This patient clearly would have neurological symptoms from this displaced thoracic spine fracture. If we see on the trauma plane film of the chest, we see rib fractures, and they're hard to pick up, admittedly. They are seen. The CT can show the rib fractures much more clearly. They're displaced, and there's some pleural fluid adjacent to it. CT is clearly, as it should be, more sensitive for displaced rib fractures, but usually they don't have treatment implications. Particularly young children, the ribs don't break that often. Older children, more like adult people, they can have rib fractures. Usually no treatment implications, unless the rib fractures are in the upper part of the chest, as is shown here. This patient had also high energy trauma and had bilateral scapular fractures. In that case, the trauma chest CT has to be done with a CT angiography technique to look for vascular injury, which is very common in that condition. So chest CT and multi-trauma is helpful. The initial blunt trauma evaluation can be done safely with plain chest radiographs. It is generally sufficient to guide the need for thoracostomy placement. Pneumothoraces that are big enough to be seen on chest X-ray can be drained. Clinically relevant findings can also be seen on the upper slices of the abdominal CT scan. So when there's a blunt multi-trauma, the abdominal CT is usually the test that is required. It's indicated. The chest CT can usually be skipped initially. If there's a need for mechanical ventilation, hemodynamic instability, and persistent drainage of air or blood from chest tubes or malfunctioning chest tubes, then a CT of the chest can be added on later on. So the primary indications of chest CT imaging in trauma in children are penetrating trauma and suspected fractures of the thoracic spine or traumatic aortic injury. There's a recent paper that discusses the implications of finding occult pneumothoraces only visible on CT in children with blunt dorsal trauma, and it turned out that unless the patient has to be intubated, they usually don't have any treatment implications. So there's some literature from the emergency room literature that validates what we found earlier, that we can be a little bit more conservative with the use of chest CT in children. And there's tension pneumothoraces, as is shown on this trauma victim. You can see here the displacement of the anterior junction line and the small pneumothorax, but there is tension there. Chest tube can be inserted based on the plain film interpretation, particularly when the pneumothoraces are enlarging over time and are not being drained very well by the chest tube. It can be helpful to perform a CT. Now in this case, you could argue that it would be better to put in a chest tube before even sending the patient to the CT scanner, because there's an obvious tension pneumothorax on the right with very dramatic findings that need to be drained urgently. Also, the position of these chest tubes can be confirmed on CT, and if they are adherent to the pleura, they can be blocked, and thereby they need to be repositioned. So small pneumothoraces only seen on CT have no treatment implications except when there is a need for mechanical ventilation. And this is an example of one of those so-called occult pneumothoraces without any implications for the treatment. This child then had bilateral chest tubes placed, and the pneumothorax on the right was not adequately drained. The lung would not expand fully over time, and you can see that there is a large amount of air collected underneath the lung. You can see on the CT the underlying problems, the lacerations in the lung, and also the chest tube not being in an adequate position to drain this pneumothorax, which collects anteriorly in the chest. Another trauma patient who had a large left pneumothorax. And on the right, we can see airspace, fluffy airspace densities. And here's the corresponding CT image, typical radiographic findings of lung contusions. They tend to spare the periphery of the lung. That's how we can distinguish this from aspiration or other forms of hospital-acquired pneumonia. Again, this is very obvious even on plain film. More subtle cases, here you can see a trauma patient who did not require any intubation. And we see there's some slight increase in density in the left lung. Sure enough, the findings are more clearly depicted on CT, but The implications of finding a small contusion on CT is basically nil. So there's no indication to do a CT to look for pulmonary contusions if they are small enough not to be seen clearly on radiographs. This, on the other hand, is a penetrating injury. A bullet penetrated the right chest, and you can see how there is consolidation, pleural fluid. There's a large defect, a laceration in the lung caused by the bullet. The bullet can be seen overlying the spine. This is the trajectory of the bullet that can be followed on CT slices in the coronal and in the axial plane. And then if you do a detailed analysis, you can see the pneumatoceles, the lacerations communicating with the pleura, and also with the tracheobronchial tree directly. So this is a traumatic bronchopleural fistula that usually requires a surgical intervention. So the emergency room physicians have been working on identifying children with very low risk of clinically important blunt abdominal injuries. They have come up with criteria and scores to decide which patients would benefit from cross-sectional imaging. And in the abdomen, it remains problematic. In the chest, I think the indications for CT are more clearly established. In children, pediatric surgeons are usually less aggressive in operating on those patients. They would only explore them if there is a hemodynamic instability. They would be reluctant to open these patients to take out a shattered spleen, because what you take out, you cannot put back, and that's why there's very few reasons to operate on those patients, except for perhaps free interperitoneal air. So what is the accuracy of the abdominal physical exam in identifying children with blunt intra-abdominal injuries? Another paper recently published. I think it's a clinical call, and we need to be responsive to our clinical colleagues. If they feel that cross-sectional imaging is indicated, we should do the CT scan, which is the most reliable test. Although some papers have recently validated the use of fast ultrasound in this clinical context. And sometimes this ultrasound is unfortunately done by emergency room physicians, so we may be out of the loop as radiologists, but ultrasound shows free fluids. There's even claims that you can see free air by fast ultrasound. I feel a little bit uncomfortable with this development, but people who advocate this say that it can reduce the number of CTs to some degree. Usually it's only reserved for low probability cases, and the high probability cases of abdominal injury go straight to CT. So what are my diagnostic algorithms that I use in our hospital? For trauma imaging, chest radiographs, first, lateral C-spine is still very valuable. Fast abdominal CT may be helpful in experienced hands, I would say, not by emergency room physicians. Initial CT when the patient is unconscious, had a severe head and neck C-spine injury. Penetrating injuries, high-velocity blunt trauma, when there's an abnormal contour of the mediastinum, which can be difficult to evaluate in children because they have big thymus. But when we suspect spinal fractures, neurological damage, and when there are fractures in the upper ribs, sternum, and in the scapula, which are associated with vascular injuries. CT follow-up when there's a need for mechanical ventilation, hemodynamic instability, when there's persistent air leak or output from the chest tubes, and when there is a suspicion of diaphragmatic rupture. Short word about head and neck imaging. We are familiar with the fact that cross-sectional imaging is very good for showing abscesses in the head and neck area. There's evidence-based literature supporting the use of CT and helping clinicians to place drainage tubes. On the other hand, we have to be careful not to overread our plain films. This is a radiograph to look for a croup, and the emergency radiologist, being not familiar with pediatric images, called prevertebral soft tissue swelling. The CT was done, and in fact, it was found out to be completely normal. And we know that pediatric radiologists are all familiar with the pliability of the pediatric airway and the expiratory status that can buckle the airway away from the spine in a normal child. Obviously, when there's a displaced cervical spine fracture, that is very clearly seen on plain films, and that leads to spinal cord compression. The CT only confirms that finding, but it can also look for associated abnormalities such as dissections in the vertebral arteries, so CT is a secondary test for those. When the plain films are limited, such as in this case, when the shoulders are clearly precluding the assessment of the lower cervical spine, the CT clarifies the issue, and this is an important injury that needs to be stabilized surgically. So a number of decision rules have also been developed in regards to C-spine imaging, and this is a general decision rule. And there's high risk factors, old age, and high energy mechanism, neurological symptoms, paresthesias. The CT is indicated. Also, when the patient is walking into the emergency room, there's a low-risk situation, there's no need to do CT. There's a delay onset of the pain, and there's no midline tenderness. Another author has determined that ability to actively rotate the neck 45 degrees to left and right is a helpful decision rule that performs better than just clinical judgment alone. So we were confronted sometimes with difficult situations. 5-year-old boy, emergency radiologist was not quite familiar or at least comfortable with this image, wondered whether there was an increased distance here. The CT is just another image of the same finding, basically. There is surely a large distance there, but we then let the child, and this is something the child has to do on his own without assistance, flexion and extension views show the normal mobility at this level. So this is again a completely normal finding. So be familiar with the normal appearances of the pediatric cervical spine, including the pseudo subluxation of the vertebrae with flexion. But this patient still had to undergo another cross-sectional imaging because, as I mentioned, scivora, cervical spine injury without radiographic abnormality, is best shown on MRI. This patient had a normal MRI. And finally, the cervical spine could be cleared. This is a pediatric decision rule. The nexus criteria, again, similar criteria as in adults, midline tenderness, neurological findings, altered levels of consciousness, intoxication probably applies more to the adult group, and then distracting other painful injury that precludes an assessment of the possibility of a painful cervical spine injury. Here's a paper that discusses the use of plain radiographs versus CT in the pediatric age group, confirming that in low-risk situations, plain films are perfectly adequate, but in higher-risk situations, in adolescents at least, similar rules can be used as in adults. This is to be a low threshold to do in CT if there continues to be pain, and sensitivity is somewhat problematic. Specificity is very high. So the pediatric emergency room literature now comes out with papers that justify the use of plain films as an initial screening tool rather than CT in children. When we do a multi-detector CT scan in a trauma victim, this is the technique that I use. No need for non-contrast imaging or multiphasic exams. We benefit from doing a CT angiography technique generally to look for vascular injury. Occasionally, very occasionally, we do delayed bladder images when there is a suspicion of bladder rupture or renal pelvis urethral injury. Observe the guidelines advocated by the Image Gently campaign to weight and size adjust the MA, perform longitudinal dose adjustment if available in the scanner, And very helpful, you can reduce the KV in children quite dramatically, particularly if you're using a CT angiography technique. The images are actually better with a lower KV, and the radiation dose is markedly reduced. Iterative reconstruction, if available, on your scanner can also be very helpful. You can do a single total scan without overlap, so you don't have to do a separate chest and abdomen CT. If you decide to do one, then just do a single acquisition. And do the coronal and sagittal reformats to look better at the diaphragmatic integrity, for instance. Here's the website from the Image Gently campaign, which is an international campaign, very successful. And it's available in many languages, translated, Arabic, French, so I believe anybody around the world is familiar now with this very successful campaign that was initiated by Dr. Marilyn Goski in the United States. So in summary, our algorithms has changed. It's a moving target, basically. Our old algorithms was basically a physician was sitting with a patient in a room, took the history, did a physical exam, formulated a working diagnosis, ordered some lab tests. Usually an X-ray would be performed, diagnosis would be made, and treatment would be instituted. This was a very individualized and operator-dependent algorithm. More recently, in emergency room settings, triage is performed often by nurses and physician assistants. So it's not necessarily a good development, but it is the way that things are done nowadays. The patient then enters a rule-out protocol. An imaging test is typically performed, which used to be up till 5 or 10 years ago a CT scan. Lab results are obtained usually after the CT scan, so the pulmonary CT is easier to get than to wait for the dimer results from the lab. Diagnosis and treatment are instituted, and then the findings are usually followed up with another imaging test, and that can be a CT scan. This is protocolized and operator independent, which has certainly advantages. So I would like to emphasize the benefit of the test. This is important for the management of the patient. You read sometimes about those so-called life-saving CT scans. You have to remember, even as radiologists who are on the receiving end of those requests, CT is just a test that provides information. It is subject to the same problems as any test, accuracy. We can see false positive, false negatives. It all depends on the pretest probability. If there's a high likelihood of appendicitis, we're more likely going to be helpful than when there's a low pretest probability. And the prevalence of the disease within the groups that we examined. What's the value of a negative test? In the United States, it's actually very helpful to do a CT to send the patient out of the emergency room because it's so expensive for patients to be admitted to hospital. So there is a value to a negative test. Is the information that we provide understood by the referring doctors? Is there some pseudo-disease that we identify, or do we identify an incidentalloma that has no implication to the management of this patient, that only leads to further workup? If the referring doctor gets a message, does it change their clinical thinking? And if they change thinking about it based on our findings, does it really change the clinical management? As I said, the clinical management is constantly in evolution. Appendicitis is now treated with antibiotics rather than surgery, and we have very little influence on that. If the management of the patient changes, does it really change the outcome of the patient? And does it then save a life? So there's a big link, a long link between the information that comes out of the CT and the life-saving effects of it. Many steps involved. Why would we overstate the benefits of CT as radiologists? Well, this is how we make our money, obviously. I'm very well aware of the economic drivers of the use of CT in my own hospital and also perhaps in your situation. Another thing is diagnostic capabilities of CT often exceed the therapeutic options. The clinician is not really interested in where the appendix is located, how big it is. They just want to know, do they have to go in and out? Do they have to operate or not? Most medical decisions are dichotomous. We rarely need the anatomic detail that is required, that is provided by CT. Most decisions are, I either have to place a chest tube or not, I have to operate on this patient or not. And so CT is a tremendously powerful technique. It provides a lot of information, but many of that information is not really that relevant to the final outcome. Standard of care is not the same as clinical indication. I want to re-emphasize that. Follow-up CT, if we do more and more CTs in patients, will surely show very dramatic findings, but there's a law of diminishing returns on that. So I would like to conclude by some future developments in this field. It's an emerging it's a moving target. I think more outcome studies are needed, not just in the United States, where we are very active in trying to develop this, but all over the world. I'm familiar that people are asking for the outcomes of our work, algorithms, appropriateness criteria. I think in pediatric imaging, we should stick to plain films, contrast studies, ultrasound screening, and then in selected cases, we can resort to CT. So we have to be familiar as pediatric radiologists with these basic modalities. Fast MR can actually replace CT for a number of indications as well, such as acute appendicitis, and this is being investigated in our hospital. So this is California, of course. They do CT scans for minor injuries, apparently, and this is on a web page that's available for the general public, together with healthy advice about eating spaghetti and meatballs and not to eat bananas or do it. People with minor injuries are increasingly getting CT scans and neck sprain. There is unnecessary spending involved. And there's now more and more agencies, even within our own profession, that look critically about the use of advanced cross-sectional imaging to reduce the cost of all of this. And it has also entered the professional literature in pediatric radiology. In fact, the appropriate use of CT is now a quality improvement initiative within our profession of pediatric radiology. Addressing the overutilization of medical imaging is discussed by Dr. Handy in radiology recently, and I would like to quote one interesting part, that when a radiologist is paid on the basis of the number of procedures he or she conducts, a recommendation for additional procedures by the radiologist constitutes a conflict of interest. An interesting statement, I thought. Here's a guest editorial from a radiologist who complained that too much imaging is being performed at the end of the lifespan of his own mother, and that's a very poignant editorial that I thought was very helpful and interesting as well. So thank you very much for your attention. I'm very grateful to be able to talk to you today. The RSNA has a very active international program, Introduction to Research for Young Academics. Travel to Chicago is funded. We have the Derek Harwood Nash International Fellowship. I would apply all of you junior colleagues to encourage you to apply for those. I would love an opportunity to visit your beautiful country one day and give a lecture in real time at you. And then there's the information that is available on the website that is internationally, universally available around the world. Thank you very much for your attention. I will be happy to entertain any questions you may have on this presentation.
Yeah. Yeah, thank you. I was just typing my comments to Dr. Westra. It was quite a beautiful presentation, and the message was really clear. I have no questions from the audience, and I just would like to invite Dr. Westra one day to our country. So I may have one question from the audience. Yeah?
Reduction doses, especially for pediatric patients, and we can do a CT which goes about
from the old one. Now you know that. So yeah, there is no CT. We have to do fast, no contract.
Sorry, do you hear me?
Yes, we are hearing you.
Yeah, thank you. I have a question from the audience here.
I was just wondering, thank you for the nice presentation. Most of the papers you showed us were dated 2011, the latest 2013. What about the use of the new dual CT, the spectral imaging for reducing the dose, especially for pediatric patients who are using these with very low dose? What do you think about these since 3 or 4 days we are using these, 3 or 4 years? Thank you.
Thank you very much for the question. I think the question is, do we use dual energy CT in pediatric patients? Is that correct?
Yes, we do use dual CT to reduce the dose, and we have special protocols for pediatrics dose reduction on our 750 HD machine.
So we have dual energy scanners as well, and it's a flash CT scanner from Siemens. It is a very fast scanner. We have very good results. We find that the dose is equal or even lower than that of conventional CT, and the benefit is that it is incredibly fast. So you can sedate, you can basically scan a child, a whole trauma patient in just a few seconds. So you're correct. We don't use the specific dual energy applications at the moment for pediatric applications. It's just that there's 2 tubes there that allow the imaging to be obtained very quickly, in twice the speed that you would do with a single tube. So, and at almost the same or even lower dose. So it's really an incredible technological development that we are welcoming. I'm very glad that in Lebanon there is similar experience, apparently.
Thank you. The dual CT of Siemens is a little different on GE because they use this is the other one 80 kV, 120 kV. The other one they combine it. That's why maybe.
Yes. Yeah. So there's even the ability to get images with 2 different kVs. So you can get a non-contrast image for free, so to speak. We usually use the 2 tubes at the same kV. And in our adult colleagues are using it for specific indications such as kidney stones and composition of pulmonary embolus, for instance. They use it at different kVs. We're just using it as the 2 tubes at the same kV in order to expedite the scanning, to be able to scan faster than we normally would have been able to.
Thank you very much.
You're welcome.
Hello, I'm here. This is Dr. Rajput.
I don't think we have other questions from the audience.
We have
Okay. At this point, I will be muting everyone's line so that Dr. Rajput can present her presentation. And Dr. Rajput, if you'd like to start your desktop share, please.
I have. Can you hear me?
Yes, ma'am, we can. And we're not seeing the desktop share.
Desktop share. I have my presentation open on the desktop.
And you'll need to go up to share, or file edit share, and then share my screen, please.
Doing it right now. Can you see it now?
Perfect. Yes, ma'am. Please go ahead.
So I'm Dr. Rajput. I'm an associate professor here at the University of Iowa in Iowa City, Iowa. So I want to thank the RSNA for this opportunity to talk to all of you today. And I hope that you'll get some insight on my talk. It's not so benign small bowel disease. And I find as an abdominal imager, talking with all the residents and about cases every day and on call, what residents seem to not be so comfortable with is the small bowel. They are just a bit afraid of it. And so I like to take a special interest in it and would like to talk to you about some of these diseases that we encounter here and maybe some of the imaging protocols that we utilize to help us evaluate for these diseases. And here's a picture of myself since I can't see you in person, but I'm also the director for the fellowship for abdominal imaging, or body as we call it here, and pretty actively involved with the medical students here, M2s through M4s that rotate through radiology, and then I've been on faculty here for about 8 years. Just a little bit of background about myself. So small bowel malignancy, these are kind of the common things that we see, adenocarcinomas, carcinoids, lymphomas, and GIST tumors. And then secondarily, we sometimes see melanoma, lung, and breast metastases to the small bowel. And I'd also include in that gyn-onc disease, and maybe not so much small bowel, but like on the serosal surfaces of the small and large bowel, which can maybe simulate actual intraluminal disease, but unfortunately can definitely cause small bowel problems with obstruction. And incidence, I think we see a lot of carcinoid tumors, and I will be talking about this in a bit later in my talk. We're a big center here at the University of Iowa in terms of carcinoid tumors and the disease and treatment, medical and surgical. We have a couple of pretty renowned neuroendocrine physicians in the kind of medical oncology side and the surgical side. So we probably see a ton of carcinoids, and as residents and other kind of faculty come and go, they always comment on how much carcinoid we have here, but you may not see a lot of it over there, but I will be spending a little bit of time on that. And carcinoid tumors have exceeded adenos, representing 44% of all small intestinal neoplasms. There's a fourfold increase in the incidence of carcinoid over the last 30 years, and I think we're getting a lot better at detecting this as well with our protocols. Slight male predominance in the neoplasms, small intestinal neoplasms. Small bowel carcinomas and carcinoids are higher in the African American population compared with the Caucasians, at least in the United States. And small intestinal lymphoma and sarcomas are higher in the Caucasian males. Imaging techniques. For occult GI bleeding in early stage tumors, it can be very helpful to get a CT. There's also capsule endoscopy, which is better than conventional CT. It's important to know that hopefully they don't have any small bowel strictures or obstruction before implementation of a capsule. Otherwise, that would not be a good thing. We use neutral or negative contrast volumen, about oral contrast agents to distend the small bowel, along with multiphasic, portal venous, and sometimes delayed phase imaging. And we find that this greatly helps to improve lesion conspicuity, especially with the volumen. As long as patients can tolerate drinking it, it gives you good bowel distension, and it's not as readily absorbed or as quickly absorbed as just water. And so we can get that distension. And since it's a negative contrast, it really helps us with the distension to see the small bowel wall and mucosa for enhancing lesions. Some centers suggest CT enterography should be performed in patients with clinically suspected small intestinal neoplasms if they've already had a normal routine CT AP for something else like vague abdominal pain, etc. CT enterography is kind of our go-to method to image these disease processes now. We're not really using fluoro. Sometimes we use MR enterography to follow up these patients, especially if they're younger. Population will try to use the MR enterography more for them as opposed to the CT to help reduce and save on the radiation dose. And like I said, MR enterography pros, it reduces ionizing radiation. And the cons, decrease sensitivity for the detection of polyps less than 10 millimeters. So here's just a quick example, and maybe all of you are pretty familiar with this. This is just kind of normal with the water or even no oral enteric contrast. Not the greatest bowel distension here with the positive oral contrast, a bit better bowel distension, but we can't really discern a lot of pathology in the bowel wall itself. It's just a bit tougher. And then with the volumen, we get pretty good bowel distension. So I'll be having some questions throughout my presentation just to kind of make sure all you guys are hopefully still paying attention and are still awake. And usually it would be an audience response, but since we don't really have that available, I want you to at least think about the answer before I put up the correct answer on the screen. So which malignancy most commonly affects the duodenum and the jejunum? So maybe you're thinking of your answers. And if you thought adenocarcinoma, that's great. So location is key. Adenos are most common in the proximal duodenum and jejunum, proximal small bowel, 2/3 of the duodenal and 1/2 of the jejunal neoplasms. 2/3 of ileal neoplasms are carcinoid. That's going to be where it's most commonly found. If we do see the primary, oftentimes we don't, unfortunately, because they're so small, but we definitely are able to see the metastases with carcinoids, especially in the mesentery and possibly liver. Lymphoma is more homogeneously distributed along the small bowel, but some studies say it might be more prevalent in the distal ileum. So next question, what is the incidence of malignancy as a complication of a Meckel diverticulum? So give you a moment to think of that. And if you thought 1 to 3%, at least a low incidence, then you're correct. Here's just an example of a lot of wall thickening that you can see, and some angular and slightly spiculated margins of the bowel. Not a lot of upstream obstruction that this lesion is causing. And on endoscopy, it's kind of ulcerating and really abnormal wall there. And so this is just a jejunal adenocarcinoma. True or false? Small intestinal adenos found in the duodenum are more commonly polypoid and arise in the periampullary region, whereas adenos found in the jejunum are often annular, constricting lesions with shouldering borders. And if you answer true, then you're correct. Adenos predominantly located in the duodenum and jejunum, with the exception of adenos occurring more commonly in the ileum in patients with Crohn's disease, just because Crohn's is more common in the ileum. Polypoid, infiltrating, stenosing may or may not be associated with intussusception, and mild to moderate heterogeneous enhancement are kind of common presentations. Short segment, usually with some component of SBO, because there's a pretty impressive, oftentimes desmoplastic reaction. Even small lesions can lead to significant obstruction. And early focal wall thickening, less than 1.5 cm thickness and 2 to 4 centimeter length without aneurysmal dilation. That's important because with lymphomas, we tend to see more aneurysmal dilation of the bowel. A focal mass or small ulcerating lesion, or maybe even an intussusception associated as a lead point. Duodenal adenos can be polypoid, well-defined lesions. High grade have more aggressive features, and 10% can ulcerate and cause bleeding. Jejunum, they can be annular, narrowing with abrupt concentric or those overhanging shouldering margins, may or may not be associated with obstruction. And adjacent mesenteric fat straining suggests extraluminal tumor. Okay, some questions to think about. True or false? Increased risk of small intestinal adeno in celiac disease. If you answered true, you're correct. That's kind of a known possible complication of that. Increased risk of adeno in Peutz-Jeghers syndrome. Definitely true. Increased risk of small intestinal adeno in familial adenomatosis polyposis, FAP syndrome. Hopefully everyone answered true. Increased risk of small intestinal adeno in the Lynch syndrome. And hopefully everyone answered true as well. So here's just a nice example of as the arrows point and the asterisk, kind of a polypoid lesion in the duodenum, second portion there, causing upstream pancreatic duct and pretty impressive common bile duct and intrahepatic duct dilation. So definitely, like on the MRCP, you'd be worried about an ampullary lesion or maybe even a pancreatic adeno-CA causing a classic double duct sign. And this ended up being an adenocarcinoma of the bowel. Here's a nice example of an intraluminal polypoid lesion in the duodenum, and this was a duodenal adenocarcinoma. Now, you really can't tell, unless there's really aggressive features, whether it's an adenoma or an adenocarcinoma, but obviously the larger the lesion is, the more concerned you are of malignancy. 89-year-old male, weight loss, abdominal pain, and melena. And you can see that there's pretty impressive areas of small bowel wall thickening in the jejunum And additionally, there are nodes in the mesentery that are enlarged next to it. There's also additional enlarged periaortic lymph nodes and a small little lymph node inferior to the liver within the ascites. And this is jejunal adeno cancer with peritoneal carcinomatosis. Weight loss in a 66-year-old male, melena, incomplete colonoscopy. And you could probably see why, because there's this big ulcerating necrotic mass at the terminal ileum area, cecum region, and there's some additional necrotic lymphadenopathy along the ileocolic chain in the right lower quadrant. And then additionally, the asterisk is pointing to a metastatic lesion in the liver, so definitely a malignant process, and very, very worried about an adeno, common things being common again, an adenocarcinoma with liver metastases, necrotic lymphadenopathy. This is a nice example from a radiographics article about showing all of the intraluminal small polypoid lesions. Small bowel is a little dilated, but some of that could just be from the volumen that was given for the MR enterography. And a lot of small lesions, some of them have a stalk, and you can see from the endoscopy all the polypoid intraluminal lesions. So if you're worried about a polyposis syndrome, you'd be correct. It's Sjirk syndrome. Another case of an 18-year-old male presents with obstruction. And in some portions of the bowel, you see the intraluminal polypoid lesions where the arrows are pointing, but not causing obstruction there. However, upstream in the proximal jejunum, there's an intussusception, which the arrows are pointing to. So you'd be worried about a lead point, knowing that there's additional small bowel polypoid lesions. And a young patient, again, you'd be worried about a polyposis syndrome, Sjirk syndrome. Next question. Carcinoid tumors typically hypoenhance on arterial phase. Hopefully everyone got this correct, and that's false, because we know carcinoid tumors are very classically, typically arterial enhancing, and that's the big reason why on our known carcinoid patients, unfortunately, they do get a lot of CT scans every 4 months or every 6 months, depending on their time of diagnosis or where they are in their treatment. But these patients we do biphasic liver protocol CTs, where we're doing the arterial phase through the entire liver, and usually ends up scanning the pancreas as well. Usually the pancreas is included in that. And so we're looking to help us identify enhancing lesions in the liver for metastatic disease from known neuroendocrine tumor. Carcinoid tumors produce serotonin, histamine, dopamine, and this results in a strong mesenteric desmoplastic reaction with local fat straining and spiculated or stellate soft tissue thickening. True or false? And that's very classically true. I'll show you some cases of that. Calcification may be present in 20% of carcinoid. True or false? And that's false, and we'll talk about that as well. Carcinoid syndrome occurs with metastases to the liver and is characterized by flushing, diarrhea, palpitations, and wheezing. Now, this is a carcinoid syndrome. And that is true, and that's a very common presentation, and it has to do with the metabolism of the serotonin once it reaches the liver that produces these symptoms. So small intestinal carcinoid, usually well-differentiated neuroendocrine neoplasms associated with the MEN1 syndrome, most commonly arise in the ileum, most occurring within 60 cm of the ileocecal valve. And they're usually very small lesions of the ileum or small intestine, often less than 2 centimeters. That's why they can be really hard to see even with a CT enterography. Sometimes we see some lesions there that are more mass-like. Other times we just might see some abnormal wall thickening in the distal ileum, maybe terminal ileum, that's kind of hyper-enhancing compared to the other adjacent bowel, but oftentimes we don't see the primary lesion. Submucosal nodule, which typically enhances avidly on arterial phase. Vasoactive substances cause a strong mesenteric desmoplastic reaction, and local fat straining, the spiculations, the stellate, soft tissue thickening, it kind of gives this spoke wheel appearance of the mesenteric metastases, and 70% may contain calcification, so that's pretty high. There may be kinking of adjacent bowel loops because of this extreme desmoplastic reaction in the mesentery, and that can lead to bowel obstruction or vascular compromise as well, maybe some underlying bowel ischemia and fold thickening. On barium, which we don't really do for these patients, but classically in the past, we might see mural thickening and thickening of the valvulae conaventes. Later, you could see some submucosal lesions that may ulcerate or produce a target or bullseye appearance that can unfortunately resemble metastatic disease, such as from melanoma or breast cancer or lymphoma or Kaposi's. We don't see a lot of Kaposi's in our patient population, but it is in the differential. Metastatic spread to the mesentery, again, causes desmoplasia, crowding of the fold, angulation, and kinking of the adjacent small bowel loops. So here's a nice example, kind of zoomed up, just to show you how small some of these lesions can be. And this patient either had volumen or they just had water enteric contrast, definitely not positive oral enteric contrast. You can see a small little intraluminal enhancing lesion. So primary carcinoid. And this is just this is a classic example of the mesenteric soft tissue mass with the spoke wheel, as it's been described, the spoke wheel appearance of the mass causing kind of the tethering of adjacent small bowel loops, and some of those small bowel loops also have an enhancing wall, which could be from vascular congestion, mild ischemia, or it could just be from tumor as well. And that's always the metastases that we see in the mesentery. It's not the primary tumor. And here is just an example. Obviously, there's some diverticuli, but an intraluminal mass, polypoid mass in the terminal ileum. And then on the CT exam, we can see the classic spoke wheel kind of radiating spiculations of this mesenteric mass, a lot of edema, fluid in the mesentery, and some associated bowel wall thickening. Very classically carcinoid. So we see a lot of this here. I don't know, I'll find out maybe during your questions if you do see a lot in your patient population. But when we see this, we always think of carcinoid first and foremost. And more intraluminal lesions, polypoid in the distal ileum. And you can see that there as well with the polypoid lesion and a mesenteric mass adjacent to it in the middle picture. And then on the far right picture, we see liver metastases and carcinoid with liver metastases. A number of intraluminal polypoid lesions are seen on this small bowel follow-through, and with the paddle there as well, so compression applied, and we can see that there's multiple intraluminal polypoid filling defects, not causing any obstruction of the adjacent bowel loops. This ended up being metastatic melanoma, but if you saw maybe just a few lesions, you could also include carcinoid in your differential. Obviously, it's very important to know if the patient has a history of a primary tumor to help you with your differential. So small intestinal lymphoma, moving on, are what type? B-cell lymphoma, T-cell lymphoma, Hodgkin lymphoma, mantle cell lymphoma, or Burkitt's lymphoma. And if you answered B-cell lymphoma, you're correct. Non-Hodgkin lymphoma of the small intestine is less common in patients with celiac disease and AIDS. And if you answered false, you're correct. So talking a little bit about lymphoma, it may be primary or may relate to secondary involvement from systemic disease. Primary lymphoma, small bowel lymphoma, No peripheral or mediastinal lymphadenopathy usually, unless it's very advanced. No evidence of hepatic or splenic involvement usually. Normal white cell count, and tumor usually involves mainly the GI tract. This is for primary disease. Secondary occurs in approximately 10% of patients with limited non-Hodgkin lymphoma and in up to 60% of patients with advanced disease. Imaging findings are variable, maybe solitary endoenteric polypoid mass, multifocal nodules at multiple sites, infiltrative form associated with mural wall thickening, destruction of the muscle wall and myenteric plexus, resulting in this luminal dilation. And this is kind of classically what residents are shown, or what residents are pimped on in conference with this aneurysmal dilation. And when you see those findings, it's interesting how lymphoma, being more of a kind of a soft tumor, not like the adenos that can elicit this desmoplastic reaction. Because lymphoma is different, even with extensive disease, we've seen a lot of cases where there's no associated bowel obstruction. And when we see that with abnormal areas of wall thickening or aneurysmal dilation and maybe adenopathy adjacent to it in the mesentery, we're definitely thinking of small bowel lymphoma. And we've also seen small bowel lymphoma in our transplant patients as well. I've had even recently a case of a post-lung transplant. Like 8 years later, they developed small intestinal lymphoma, biopsy proven. And so we see it in the post-transplant lymphoproliferative setting where it can affect the GI tract. Exophytic, exoenteric growth with necrosis and cavitation, rarely fistulized. Although I have seen some cases of perforated small bowel lymphoma, not really fistulizing, but just kind of localized perf, because it weakens and distends that wall. Bowel obstruction is less prominent versus the obstruction seen more with the adenos. And more homogeneous, mild enhancement on CT, less contrast enhancement than other small intestinal neoplasms, definitely less enhancement than the carcinoids. Regional mesenteric lymphadenopathy is typically bulky, and ileum is the most common site because that's where most lymphoid tissue is for the primary small intestinal lymphoma. So here's just an example of kind of this area that's kind of dilated, maybe even ulcerated in the distal small bowel, and a lot of abnormal angulation, spiculation of distal small bowel. So this is a giant cavitated lesion displacing adjacent small bowel loops, and this was focally thickened, smooth lobulated folds. These were both cases of lymphoma, but can be very hard to tell, obviously, if you don't, have some history to help you out with that. This is showing a number of small intraluminal filling defects, multiple small bowel nodules, and kind of an area that's narrowed there as well, and suspicion that there's kind of a dilated portion of bowel adjacent to it. And here we see a lot of mesenteric adenopathy and this focally dilated bowel loop with some suspicion for some wall thickening. And this was lymphoma. With the lymphadenopathy, the classic sandwich sign, if you read about that or teach that to your residents in training, the sandwich sign with all the mesenteric lymphadenopathy encasing but not obstructing the mesenteric vessels, very classic for lymphoma. So with the small bowel involvement, you also have suspicion that there's lymphoma in the bowel adjacent to it. And here's an example of very persistent wall thickening, luminal narrowing with the oral contrast, but no associated bowel obstruction, lymphoma. So which of the following is true about a gastrointestinal stromal tumor? Moving on to the gist. Lesions are predominantly located in the ileum. Only arise in the small intestine, not the mesentery or omentum. And we're just looking for the true answer. Gist can vary in size between a few millimeters to more than 30 cm. Classic smooth lobulated contour on imaging excludes malignancy, or rarely have central necrosis, dystrophic calcification, hemorrhage, or ulceration. So if you answered C, you're correct because they can definitely vary in size. They're rare, but again, we tend to see, I think, a decent amount in our population. They're rare mesenchymal neoplasms that arise from the interstitial cells of Kegel in the subepithelial bowel wall. So they are below the epithelial mucosa, so submucosa, represent less than 10% of all primary small intestinal neoplasms. Submucosal, smooth, round, oval filling defect in the small intestinal lumen. And if it's subserosal, extrinsic or exocentric masses that displace adjacent bowel loops. And if it's intraluminal, tend to be hypervascular with hemorrhage and ulceration. Very common cause for GI bleeding. That's the most common presentation of GIST is GI bleeding. So here's an example. You might think, oh, she was talking about lymphoma, and this looks like lymphoma. And it very well could be, but this ended up being gastrointestinal stromal tumor. But what we do see is more kind of some areas of heterogeneous enhancement in this large exophytic mass. It's not causing any bowel obstruction, but it is cavitating to a certain degree, and this was a GIST. But if you thought lymphoma, you definitely would be correct in your differential. Here's a intraluminal polypoid lesion, and the top right picture is pointing to a little crater, an ulcer, that's pooling the oral enteric contrast. So it's an ulcerating mass, and from the endoscopy, you can see the large polypoid lesion, and from the fluoro study in the bottom right, you can see the little crater or ulcer, and this was a gastrointestinal stromal tumor. Again, lymphoma can also ulcerate, so lymphoma would definitely be in the differential. Primary adeno of the stomach, it's possible, but maybe a little less common. I probably put that third in my differential just because of this is kind of a very localized large mass. This isn't a classic linitis plastica by any means. And what is the main site of metastatic disease in the GI tract? Small intestine, so if you answered that, you're correct. Small intestinal metastases. Most frequent extra-abdominal causes of small intestinal mets are melanoma, lung, breast, and thyroid cancers. I must say I don't see a lot of metastases from thyroid to the small intestine, but melanoma, lung, and breast definitely we see. Metastatic spread to the small bowel usually appears as a smooth, round, or polypoid mass with the target sign indicating ulceration, and then that could lead to intussusception or bowel obstruction. And METs can also occur as extramural nodules following the intraperitoneal seeding, as I mentioned earlier in the presentation. Very common with the gynecology, oncological cancers, appendix, and colon. And this is a nice example of an intussusception. And I'd be worried about a lead point causing this, and that you can see some adjacent dilated small bowel loops, so it's associated with the bowel obstruction. Example of intussusception. And if you're looking at this, you're thinking there's a lot of ascites. This is true. And one thing that I might point your attention to is this very small structure. And this was really tough to call, and I'm not sure if it was really well noticed on the first scan looking through it, but you see this partially calcified, somewhat tubular structure down here in the right lower quadrant. This patient had oral contrast, and you can see this tubular structure with a thin kind of peripheral wall to it, dilated, and that ended up being the appendix that is clearly dilated. And with all of the ascites and this omental thickening, this was a pseudomyxoma, peritoneae, appendiceal mucinous tumor, low grade, but still, nevertheless, appendix was the primary. These can be really hard, I think, to call because, especially if there's a lot of carcinomatosis and ascites, it can be very difficult to find the appendix. For a lot of these patients, we're not giving the routine positive oral enteric contrast anymore, And so to even help you find, the appendix can be really tough. But I think the oral contrast in this case really helps to show that, especially since the oral contrast isn't in the lumen of the dilated appendix, also makes you think that it's obstructed. And that's it. Those are some of the articles that I cited and referenced in my talk. And I thank you. I hope this was a bit educational and maybe got you thinking a little bit about small bowel tumors, which I don't think we think a lot about, but definitely when you see it and when you have to think about it, maybe hopefully you can have this as a reference. Thank you.
And your lines are now unmuted.
Jimmy, can you do it so that we can be heard?
I'm sorry?
Yes. Yeah, thank you. It was a beautiful presentation. We have one question here from the audience.
If there's a difference between على السطح شيء على السطح. Is there any difference between pseudomyxoma peritonei and mucinous tumor of appendix?
Yes. Oh, well, I say that there's pseudo. Yes, you wanted to know the difference between the two, correct?
Yes.
Yes. I will say that something is pseudomyxoma peritonei when I see rupture, meaning I see implants and ascites that has mass effect, like the classic scalloping along the liver or the spleen and the upper abdomen. And I'll be looking for peritoneal and omental implants, carcinomatosis. And with ascites, then I think that there's pseudomyxoma peritonei. But it usually has that scalloping, loculation, mass effect on the bowel or organs, liver and spleen that you don't see typically, with just simple ascites. Versus a mucinous tumor of the appendix may or may not be ruptured, and if it's not ruptured, it's just usually we just see a dilated appendix, may or may not have wall calcification, and usually no adjacent fat stranding, no appendical lift, so not acute appendicitis. They may be imaged to evaluate right lower quadrant pain and rule out appendicitis, but we see a dilated appendix, usually pretty big, like maybe 15 millimeters, greater than 2 centimeters, with those findings, lack of acute inflammation, then I think of mucinous tumor of the appendix, either mucocele, which is low grade, or some other mucinous low or high grade. But the higher the grade, then probably more disease elsewhere, or it's ruptured. Does that help?
Yeah, thank you. What protocol do you use for imaging small bowels? Do you systematically use enteroscan with yeah?
What scan did you say?
What is your what protocol do you use for small bowel imaging?
If it's just routine abdominal pain and we don't know a lot of history about the patient, we just do our routine portal venous phase abdomen pelvis. But if there's known small bowel disease, inflammatory bowel disease, Crohn's, potential complications of Crohn's, or like the small bowel tumors, then we do CT enterography where they drink the volumen to give us distension.
CT enterography, yeah.
Do you have the volumen, the negative oral contrast?
No, we don't have it here, yeah.
Okay. Yeah, we've been using that pretty regularly now for many years, the volumen.
Yeah.
And we also use that. you want more information on it, I can always get that to you. There's a little bit of cost associated with it, but I think, if you're using I don't know if you're just using water soluble like gastrografin, the positive oral contrast. Are you using that regularly for your bowel prep?
I mean, whenever needed, yeah. We use gastrografin, yeah.
Please, thank you for the presentation. Do you use the mannitol and glucagon to decrease the bowel movement?
Very good question. We use glucagon for our MR enterography, but we do not use it for the CT enterography. I guess we find
you did not try it.
Because, I'm sorry?
You did not try it for the CT, the mannitol?
No, we don't mannitol in the CT, no. Because the CT is so quick, we don't find that it really makes that much of a difference. But for the MR enterographies where they drink volumen, we do give them glucagon to help with the peristalsis or decrease the peristalsis. As long as they're not diabetic.
All right. Thank you very much.
Okay, thank you. Any more questions?
No, thank you.
Okay, thank you.
For the new generation من زمان كل واحد مش موجود. كان يعمل diagnosis على small bowel series. يعني اليوم we should do the diagnosis on small bowel. كثير مثلا كنا عم نحكي الله يرحمه الدكتور صاروخ.